Greetings, friends and colleagues, and welcome to this year's first meeting of My Health, My Responsibilities. As we begin, I'd like to acknowledge that UBC's campuses are located on the traditional, ancestral, and unceded territory of the Musqueam, Squamish, Tsleil-Waututh, and Syilx Okanagan nations and their peoples. As a community of learners, we have much to learn from the Indigenous stewards of these lands. During Dr. Liu-Ambrose's talk, we ask that you all keep your devices on mute. After the presentation, there'll be time to ask questions, and you're welcome to write your questions in Zoom's chat function or raise the hand in the React or Reactions function at the bottom of your screen. If you do raise your hand for a question, please remember, or the hand on the screen, please remember to lower it after you've been called on. At the end of the meeting, I'll ask you to complete a very brief poll about the future of this series, the My Health, My Responsibility. This is actually not a new series, but one that has been inactive since the pandemic. And when we get to that point, Sarah will tell you more about the poll. Now, it gives me great pleasure to introduce Dr. Teresa Liu-Ambrose. Reading the record of her many honors and current work makes me particularly grateful that she has agreed to spend an hour with us today. And I don't quite frankly see how she managed to do it. She's a very busy person. She's a professor in UBC's Department of Physical Therapy, where she holds a Tier 1 Canada Research Chair. She's the director of the Aging, Mobility, and Cognitive Health Laboratory at UBC and the Falls Prevention Clinic at VGH, and is also the co-director of the Center for Aging Smart at the Center for Hip Health and Mobility. She leads the Canadian Longitudinal Study on Aging data collection site at UBC. I know some of you are participating in that study. She also leads that study's neuroimaging working group and COVID-19 brain health study. All right. Okay. And she co-leads the study's Healthy Brains, Healthy Aging Initiative, which is why I thought it would be great to invite her to speak to us today. Her research focuses on understanding the role of lifestyle interventions, particularly exercise, in promoting cognitive and mobility outcomes for older adults. Her research results have already been implemented into clinical practice and community programs and international practice guidelines and recommendations to promote healthy aging. In her presentation today, Dr. Liu-Ambrose will highlight the evidence and knowledge gaps regarding the role of physical activity in promoting brain health as we age, highly relevant to our community. Welcome, Dr. Teresa Liu-Ambrose.
Great. And thanks, Carolyn, for that very kind introduction. And also thank you for the invitation. So I'm just going to take a moment and set up my slides to share it. And if I can just get a hands up just to make sure that everyone sees it okay before I start. Good. Okay. Thank you. Again, thanks everybody for having me and thanks for taking the time to join today. So as Carolyn shared, what I'd like to do today is to talk about the evidence that we have regarding the role of physical activity in our brain health. And again, just before I start, I just did want to acknowledge again that we are situated on the traditional and unceded territories of the Musqueam people, and that, you know, I certainly am very grateful to live, learn, and work here. The park that really flanks our campus is probably one of my favorite places in the world. And here, I just want to share that recently I managed to get a really nice photo of a woodpecker while going through the woods with my dog. So again, just a privilege. Okay, so regarding the topic at hand today, so when it comes to aging and cognition, I think all do recognize that to some degree there is a general trend whereby people's cognitive processes may decline with aging, such that here is a graph from a very kind of older paper whereby on the vertical axis we have cognitive scores or how people are performing, and then on the horizontal axis we have people's age. this particular study, people are being followed over time, and that's why we have these connections between the various data points. And the red line indicates that general trend that we often, I guess, expect with aging is that people's performance tend to decline as they age. But I also want to highlight that there's a lot of variability, and that's indicated by the blue line that flanks the red line, so that there is quite a bit of differences between people as to how they're performing as they age. And notably, what I've flagged is two individuals, one in the green and one in the blue. And what you can see is that even though their age is quite similar, so about 70 versus 80, their cognitive performance is actually quite different. And so in the area of cognitive aging, we're really quite interested as to why there is such a, variability observed. And at this time, what I like to do is introduce you to my parents. So my dad is on the left and my mom is on the right, if you're looking at the screen. And in the middle is Jamie. He's my oldest. He also just got married this summer. But I just wanted to share with you that my dad is 92 years old and my mom is now 89. And my dad is not without history of conditions. So he had a sort of transient ischemic attack in about 2012, whereby we were having lunch, and all of a sudden he really showed quite significant impairment in sort of his ability to remember everyday information, including our house phone number that we've had, I don't know, ever since I think 1980. He just really seemed to have sort of poor thinking abilities quite acutely. So I took him to the VGH emergency, and there, they diagnosed him with probably a transient ischemic attack or a TIA. And as well, they followed up with neuroimaging. And not surprisingly, on neuroimaging, it showed that he had quite a bit of what we call cerebral small vessel disease, meaning that even though he hasn't had a stroke, much of his blood vessels did show compromised blood flow. He also has type 2 diabetes for quite a few years now, and these are conditions that typically have a negative impact on your cognitive health. Nevertheless, my dad is doing pretty well. He is still very aware of all things politics, loves to stay current with, what's happening world in terms of the global situation, in terms of just general news. He still manages his own finances. He still files his own taxes, and he still oversees his rentals. He has two houses that he rents out, and he still manages very well. So in many ways, he's an example, what we call someone being quite resilient. So he does have risk factors or actually frank pathology that should predispose him to have more kind of significant cognitive impairment, but yet he is resilient such that he is able to maintain cognitive function despite pre-existing risk factors or pathology. And so, what dictates a person's resilience? Or what contributes to people's variability as they age in terms of their cognitive function? Well, we know there are several factors, including one's genetic. So there are certain genetic profiles that may predispose you to developing cognitive impairment as you age. But we also know that your environment can play a huge factor in how you cognitively age. And when we talk about environment, we're really talking about quite broadly things such as your lifetime education, your social network, your nutrition, your sleep, your stress, and of course, today we're going to talk about the role of physical activity. And I also want to highlight that, genetics also intersects with your environment. So this is where the epigenetics components comes in. And these factors all contribute to one sort of, again, capacity to remain resilient as they age, or another term that's often used in the literature is cognitive reserve. Again, the capacity for the brain to continue to maintain cognitive abilities despite frank disease or pathology. And when it comes to physical activity, I want to highlight that there has now been sufficient evidence to suggest and to have international organizations such as the Global Council on Brain Health to put out public recommendations such that, we should engage in an active lifestyle and regular exercise to maintain brain health as we age. And the evidence for organization that and the evidence that has been shown to support these statements are really derived from two sources: cohort studies as well as randomized controlled trials. And so today, what I'd like to do is really summarize key evidence from both study designs. And so here, just very briefly, I want to highlight when we talk about cohort studies, these are typically observational studies. So the Canadian Longitudinal Study on Aging is a key example of a cohort study whereby we essentially follow people over time. And then we look at relationships such that, what is the relationship between someone's physical activity level and their relative risk for developing cognitive impairment as they age. We don't intervene as investigators. We simply observe and repeatedly measure people across time. And from these studies, there is this consistent positive finding whereby higher physical activity is related to a reduced dementia risk. So here is an example from a key study that was published back in 2006, whereby essentially that they are showing individuals who report being physically active 3 or more times per week, as indicated by the darker line, have a higher chance of remaining dementia-free as they age as compared to people who report being physically active less than 3 times per week. And again, similar findings has been replicated across different cohorts. And at this time, I just want to highlight another study that included neuroimaging, and this was done by my colleagues in Pittsburgh, Kirk Garrison and Katerina Rosano. So the cardiovascular health study was a multi-site cohort study conducted in the United States, but they collected neuroimaging at the Pittsburgh site. And so here, they quantify physical activity pretty roughly, and it was just really by a single question, which is how many city blocks do you walk per week? And then, as you can see here from the flow chart, is that they also collected neuroimaging at 2 time points. And they also then follow people to look at who then ultimately developed mild cognitive impairment or dementia or remained cognitively normal over time. And so what did they find? Well, they basically found people who reported walking more than 1 kilometer per day maintain their brain matter over 9 years, specifically gray matter, and also reduce their risk of cognitive impairment over 13 years. And I'm going to pause here for a second and just ask people to share with me what is 1 kilometer, roughly. Anybody? So since everyone's being really shy, 1 kilometer is equivalent to walking 2.5 times around a standard track. So if you go to, any high school where they have a track, if you walk 2.5 times, that's 1 kilometer because it's 400 meters per cycle. And often, when we think about physical activity and why people don't engage in regular physical activity, people often talk about they don't have time. And I just want to reiterate here is that assuming a walking speed of about 1.24, which is sort of the average walking speed of an older adult, a 1 kilometer walk would be about 13 minutes or 13.5 minutes. And my whole point here is that the evidence would suggest that when we are talking about the positive effect of physical activity on brain health, we're really not talking about an extensive amount of exercise, certainly not necessary to be training for a marathon or even half a marathon. And that when we're talking about the time requirements, it is generally a manageable amount of time. That said, there are still limitations to the evidence generated from cohort studies. So as again, just to reiterate, for cohort studies, we're just observing, we're not intervening. And so as a result of that, there's still some, concern regarding the level of evidence when it comes to causation. And so here's an example whereby, when we think about evidence from cohort studies as to the role of physical activity in reducing dementia risk or in promoting cognitive health overall, we need to be concerned about the issue of reverse causation. So here's another example of a cohort study that was aiming to look at, the hypothesis that physical activity would reduce the risk of dementia in older adults as we age. And so this is data from the Whitehall 2 cohort study, a very famous cohort study. And surprisingly, or maybe not surprisingly, but overall, they actually didn't see an association between physical activity and subsequent cognitive decline 15 years later. So it is counter to, some of the evidence I already shared. However, what they did find, and is at the bottom of the slide here, is that physical activity in people with dementia began to decline up to 9 years before the diagnosis, and that the difference became more pronounced at diagnosis. So just to really kind of expand on that, here is a graph that they shared in the paper. Blue represents people who remain dementia-free. And then on the horizontal axis, you have years before dementia diagnosis. So 0 would be when they were diagnosed with dementia. Okay. On the vertical axis, we're looking at people's level of physical activity in hours per week. Red indicates individuals who ultimately were diagnosed with dementia. And what you can see here is that essentially before the diagnosis of dementia, those individuals who ultimately did end up being diagnosed, they started demonstrating a reduction in their physical activity over time, suggesting that essentially some of the quote positive relationship we observed previously regarding physical activity and dementia risk may be attributable to reverse causation, such that it isn't so much that physical activity is protective, but rather people who are predisposition to develop dementia, they behaviorally will start reducing their physical activity. And because of this limitation in evidence from cohort studies, we still need to draw on randomized controlled trials. And so randomized controlled trials are distinct from cohort studies such that as researchers, we specifically intervene. We recruit individuals, we measure them on outcomes of interest, we randomize them to different groups, and one of the groups should be the intervention that we are most interested in studying. And then we also then reassess them after the intervention has been delivered. Typically, randomized controlled trials are much smaller in terms of sample size due to resources, but over the last few years, we've had some really amazingly large RCTs or randomized controlled trials, such that in the US, they just completed and published a trial with over 2,000 individuals. In randomized controlled trials, when we think about cognition, we often are most interested in two aspects. So cognition is an umbrella term, and there's different aspects of cognition. The domains that are most studied in both cohort studies as well as randomized controlled trials of related to cognitive function and aging is memory, because it's obviously commonly impaired in Alzheimer's disease, is also quite predictive of progression from cognitive impairment to dementia, as well as executive functions, which are what we call higher order cognitive processes that allow us to plan, execute on the plan, make appropriate decisions, and also to be able to multitask. Executive functions are also quite sensitive to aging effects, and often they can decline, but we don't notice them as much because, it's much more dire if you can't find your keys in the moment. But if, let's say, you don't execute on a plan, perhaps the consequences are not as immediate. So changes in executive functions are actually just as common as changes in memory, but perhaps we don't always notice those changes as much as we notice within the context of memory. Now, while we know that overall physical activity and exercise may be beneficial for cognitive health as we age, there's actually a lack of precision in how we would recommend exercise to individuals who are interested in promoting their cognitive health. So really, in a nutshell, there's still a lot to be done, even though there is a lot of now public messaging that we should engage in regular physical activity to protect or to maintain our brain health. And some of the areas that our research program is quite focused on is the what, who, how, and when. So when it comes to the what, we're very much interested in the type of exercise. In terms of who, we're very much interested in differences between sexes, so whether males and females actually respond differently. In terms of the how, that's a really big area of research because we actually know very little as to how exercise promotes brain health or helps us perform better in their cognitive abilities. Within our lab and sort of, I would say globally, most of us use neuroimaging, and the blood biomarkers are also quite common as well. And for today, I'll be focusing on the what, who, and how. Although just to say that within our research program, we're also very interested in the when. And right now, when it comes to critical windows to intervene for promoting brain health and aging, we do recognize that midlife is key because that's an area where when we commonly start accruing chronic conditions that is bad for our brain health, such as type 2 diabetes, high blood pressure, high cholesterol. But I also want to emphasize now that there's growing recognition that perimenopause in itself may be a critical window to promote females' brain health. But again, I won't be speaking much more about that moving forward. So when it comes to the type of exercise, I want to share that aerobic exercise is the most studied in brain health, hands down. So aerobic exercise refers to anything related to exercise that increases your cardiovascular fitness or heart health, such as running, cycling, swimming. And then the second sort of most common type of exercise that's studied within the context of healthy aging is resistance training. So exercise to improve your muscle strength, mass, or muscle power. That said, I do also want to highlight there are other types of exercise that could have good utility in promoting healthy aging, and those include anaerobic training, balance and agility training, and as well as Tai Chi dance. Now, when it comes to aerobic training, again, as I emphasize, it is the most studied in the brain health. And I think in part is because we can also study it well in animal models. And by pairing animal models with human studies, we can glean or better understand potentially how this type of training is beneficial for the brain. Because in an animal model, we can, at the same time have them run on treadmills or running wheels, excuse me, and then sacrifice them and then look at changes directly in the brain. And a key study that's been published in the area of aerobic training and brain health and otherwise healthy older adults was published back in 2011 by Kirk Erickson. He's really well established in the area of aerobic training and brain health. So he completed a study whereby older adults, again, cognitively healthy, engaged in 3 times per week of walking program over 12 months as compared to an active control that did stretching exercises. And what he found is after 12 months of training, those who were in the walking program not only improved in their cognitive performance of spatial memory as compared with the active control, but through neuroimaging, he also found that the hippocampus, which is really our memory center, actually increased the volume by 2%. And now I totally appreciate that 2% may not sound so impressive, but I also want to share with you, we also know that essentially by the time we hit 50 years old, the hippocampus starts shrinking in size, even without any sort of frank pathology. And so it's been estimated that your hippocampus could shrink up to 1% per year. And so when you think about the fact that if you walk for 12 months and can increase the hippocampal volume by 2%, you're literally reversing its age by approximately 1 to 2 years. And so then what about resistance training? So as compared to aerobic training, resistance training is less studied, although that has been changing the last decade or so. And resistance training really has been the type of exercise that I've been very focused on in my own research program. Now, resistance training is important for healthy aging and for cognitive health or brain health. First, I want to share that when it comes to skeletal muscles, they comprise 30 to 40% of our total body mass, which is, quite significant. And as we age, we tend to lose muscle strength, mass, and function. And this loss is actually associated with cardiovascular conditions and their progressions. And that may be a linkage that many of you may not be fully aware of, such that, the quality of your muscle is actually related to potentially your heart health as well. And the other aspect I want to highlight is that we're now also understanding it's not so much how much muscle mass or how strong you are, but the quality of your muscles. So that what we're now discovering is that if you have muscle that is actually infiltrated with, but that in itself will predispose you to conditions such as high blood pressure, insulin resistance, as well as type 2 diabetes. And these conditions all collectively are detrimental or have a negative impact for your brain health. And again, historically, resistance training really wasn't on the radar when it comes to as a mode or type of exercise for promoting cognitive health. And some of the reasons might be because, again, we don't have good animal models of resistance training. It's easy to train a rat aerobically because, again, we can put them with, house them with running wheels. But thinking about how to get a rat to, quote, engage in resistance training takes a little bit more creativity. And I think also too, there's just this historical notion that somehow resistance training is not safe for older adults. I'm a physical therapist by training. And certainly I recall years back, when we're learning about different conditions and exercise prescription, we were always told that, when it comes to individuals with osteoporosis, we really need to be careful and that we don't want to overload them in the case of sustaining fragility fractures. And we now know that, if you are engaged in resistance training with appropriate advice, there isn't an increase in adverse events, just like anything else. If you do it properly, it's actually quite safe. And if anything, lifting weights is critical in maintaining your bone health. And the other piece is that resistance training is just less familiar for most people. Most of us grew up, engaging in classes that or physical education classes where we ran, we did the 6 laps or something to that effect, more aerobically based type of exercise engagement. While, engaging in strength training is really typically more specialized and not as universally exposed to everybody. So one of the first things I did at UBC actually was to conduct a study to look at the impact of resistance training on both cognitive and brain outcomes and otherwise healthy older women. And at that time, I just want to share, again, resistance training really was not viewed as a viable option for promoting cognitive health. A key reason as to why I constrained this particular study to older women only was because even back then, there was some suggestion that men or males and females may respond differently to exercise when it comes to cognitive outcomes. So for this particular trial, we recruited 155 community dwelling women aged 65 to 75 years old, and they were randomized either to once a week of resistance training, twice a week of resistance training, or twice a week balance and tone exercises. So in this particular class, they would actually engage in simple balance exercises or do some functional strength exercises. It just was not progressive in nature in terms of resistance training. And all 3 programs lasted for 12 months. In terms of outcomes, obviously, we measure cognition. We focus on executive functions. Again, these are higher order cognitive processes. And we probed this domain using 3 specific cognitive tests. And the one in bold, the Stroop Color Word test, was our primary outcome. And then in the subset of individuals who were eligible, we also acquired neuroimaging, specifically structural MRI, to quantify white matter lesions, which is representative of cerebral small vessel disease. And I'll talk about that a little bit more in the next couple slides. But just to allow each of you to understand what we put our participants through, I want to share with you what the Stroop color word test is. So I just do want you to try this. So here you see a number of, text or words of color. And the task here is actually to say out loud the color in which the word is printed. So as an example, for the top left hue, that the text actually says yellow, the correct response actually would be blue because it's printed in blue. So in your sort of own space right now, I just like you to try going from each row, so going from top to bottom as quickly as you can, say out the color in which the word is printed, but don't read the word. So give that a try, and if someone can just share with me what they find they are doing. Do people find it a fairly easy task?
I found it quite difficult.
Yeah. And it's difficult, and it's designed to be difficult. It's designed to really have you do what is intuitive, which is to read the word, right? So I think most of us would automatically want to say yellow, yellow, green, blue, 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 rather than say blue, red, blue. And really what we're testing here is your ability to inhibit and then to make an alternative choice. So this is the Stroop color word test. It's a classic way of probing what we call response inhibition, and it's part of the executive processes. Now, I had briefly mentioned we also acquire neuroimaging, and specifically we were after what we call white matter lesions. And again, white matter lesions are actually very common in older adults. As I mentioned, for my dad, that was what they found on his neuroimaging after he had his TIA, just a moderate amount of cerebral small vessel disease as indicated by white matter hyperintensities. I'm just going to take a second here to explain that a little bit more. So essentially with age and also with chronic conditions such as high blood pressure, type 2 diabetes, and poor lipid profiles, what can happen is in the brain, we can develop what we call cerebral small vessel disease. And what happens in cerebral small vessel disease is that the vessels that actually feed the brain, and the brain is very, very kind of a hungry organ. It needs a continual supply of blood at all times. What happens with cerebral small vessel disease is that you end up having little episodes of ischemia, meaning that, small blockages of blood flow so that you have essentially bits of your brain tissue die due to the lack of nutrients, but it's not a stroke. It's not significant enough to actually be experienced as a stroke, but it's at a sort of much smaller level of insult. But on neuroimaging, we can see it as these bright white intensities, and that's what I'm showing you here. So this represents a white matter lesion due to cerebral small vessel disease, and often is what we due to ischemia or the lack of oxygen or nutrients. And then other times it could be resulting in lacunes, which are larger insults and often are more fluid filled, and therefore they show up darker, but with a distinct hole in the brain. What is quite, I guess, important to note is that people can have cerebral small vessel disease and be asymptomatic. Again, it's not like they would have stroke-like effects at all, but they could have very mild deficits. And then as the disease progresses, that's when people become symptomatic. And so just to really highlight that cerebral small vessel disease is actually highly prevalent in aging. It's been estimated that by the time people are 65, about 90% of us will have evidence of cerebral small vessel disease, meaning that if we scanned our brains, 90% of us will have these white hyperintensities. Even though they're clinically silent, they are associated with vascular cognitive impairment, so cognitive impairment due to vascular disease in the brain, and it is the second most common type of dementia. But I also want to highlight, if you look at the risk factors, other than age, they're highly modifiable. We know that exercise can moderate high blood pressure, type 2 diabetes, and poor lipid profiles. So within this particular trial, first I want to share, we did find benefit of resistance training on our primary cognitive outcome of executive functions as measured by the Stroop Color Word Test, whereby after the intervention, both groups of resistance training show better performance as compared to the balance and tone group. And within the context of neuroimaging, so again, remember, we recruited otherwise healthy individuals, but not surprisingly, the majority of people who underwent neuroimaging also showed evidence of cerebral small vessel disease. And what we found is that those individuals who were in the twice a week resistance training actually showed reduced progression of the disease as compared to the active control after 12 months. And I just want to highlight this was actually one of the first time within the literature that there was evidence to show that exercise can actually moderate existing disease within the brain. And since our publication has been replicated by other research groups as well. So then this leads me to the question of, well, then can exercise benefit those with impairment? So I've shown you some evidence to support the notion that exercise can be a benefit for otherwise healthy older adults. Well, what about those who already have pre-existing cognitive impairment? So here I'm sharing with you the results of a trial that we actually have not published yet, but we have submitted the results to journals for peer review, and it is being reviewed at this time. So for this particular trial, we still focused on resistance training because, again, we do really have a strong hypothesis that resistance training could be of significant benefit for healthy aging. And in this particular case, we included people with vascular cognitive impairment, and that's defined as individuals who have frank cognitive impairment but no dementia, and that their cognitive impairment is most likely due to cerebral small vessel disease confirmed on neuroimaging. And for this particular trial, we recruited a smaller sample of 91 individuals, and they were randomized either to resistance training or to an active control, and again, was also 12 months in duration. Again, the results were not published, but we did publish a study protocol. And just to share who we recruited, because this is important. So again, we did recruit individuals who had objective evidence of impairment in their cognition, and that was indicated by their Montreal Cognitive Assessment Score. So this is the same test that Trump has taken in the past and said that he scored really well on. But it is a very widely used screening test to detect subtle changes in one's cognitive function. But in addition to that, we also needed evidence of cerebral small vessel disease on neuroimaging. And this criterion is what really creates a difficulty in recruitment, because obviously people don't just get their brain scanned without any reason. And so the recruitment piece really was limited by having this particular factor. At the same time, though, it did give us more a better understanding of who we're recruiting, and also allowed us to essentially capture a more homogeneous group of participants, and with appreciation of what likely is driving their cognitive impairment. We did exclude people with dementia and in any individuals who are unable to exercise safely. And here I just also want to highlight that our resistance training protocol was progressive, and this is important. So it was not a study whereby you enrolled and for 12 months you did the same exercise at the same load for the whole duration. We worked our participants quite hard. About every 4 weeks, we would reassess their loading, and if they were doing well, we would increase their loading so they're always, again, progressing in the weights that they're lifting throughout the 12 months. And then in terms of the active control, that key point I just want to highlight here is that they also came twice a week, and they did engage in exercises. And so it was not a do nothing control group, but rather, a comparator that would match probably what most community centers offer to most older adults. In terms of outcomes of interest for this particular study, we were interested in both people's cognition measured by the ADAS-Cog Plus. And so this is a measure of global cognition, so it wasn't domain specific. It tapped into memory as well as executive function, and then we create a composite score. And then we were also interested in white matter lesions because, again, this was a sample of individuals who had pre-existing cerebral small vessel disease. And so what do we find? Well, pretty consistent with the finding of our prior trial in otherwise healthy older women, we found that there was a significant effect of resistance training on our primary outcome of global cognition. In terms of white matter lesion volume, so here, this is where the results are a little bit, needs a little bit more dissection. So we didn't see an overall effect of resistance training on white matter lesion progression when it comes to the total volume and across all participants. But what we did find is that if we look at, sex differences, females who were trained with resistance training did show benefit as compared with males, meaning that for those individuals, for females, their white matter lesion progression was reduced by resistance training, but males did not. We also did additional exploratory analyses looking at different lobes of the brain. And in those exploratory analyses, we did find that resistance training was significant in reducing progression and white matter lesion load in the temporal lobe, as well as the splenum. And what's also quite interesting is that there is a brain-body connection. So here I just want to pause for a moment and emphasize that even though at this point I've been emphasizing the role of exercise in promoting both cognitive and brain outcomes in older adults, I want to highlight that by promoting your brain health, you may also be promoting your physical mobility. Because obviously for you to move easily through your environment is dependent not only on your joints, but really on your brain, because your brain is really what coordinates your body, right? And certainly impaired mobility and falls is a concern in older adults. And our program really has shown that one of the ways by which exercise promotes mobility outcomes in older adults is not only through the physical aspects, such as increasing your strength or increasing your balance, but also by promoting your cognitive health and promoting your brain health. And so here what we see is that reduced progression in the temporal lobe as a result of the resistance training was actually significantly associated with improved mobility as measured by the short physical performance battery. And then lastly, for the last study I want to share today is also just to emphasize that there is evidence to show that aerobic exercise is also beneficial for individuals with pre-existing cognitive impairment. So for this particular study, again, we focused on individuals who had cognitive impairment due to cerebral small vessel disease, but the intervention of interest now is aerobic exercise. And in terms of the aerobic exercise, it was not indoors on the treadmill or on a stationary bike, but rather a walking program, very similar to the one that my colleague Kirk Erickson did in otherwise healthy older adults. And here what you can see is that in terms of who included, they were pretty, diverse in their physical mobility, right? So here in the background, we have an older gentleman who's navigating with a walker, and then we have other individuals who are much more stable on their own. And so what do we find? Well, we found after 6 months of walking 3 times per week, again, it was progressive over time. So it wasn't just an easy walk. We measured people's baseline fitness level and then tailored their target heart rate as a starting point and continued to monitor that throughout the 6 months. So after 6 months of this progressive walking program, we did find an improvement in our primary outcome as measured by the ADAS-Cog. And I also want to emphasize that the degree of change we saw in this particular measure was actually the same degree as prior pharmaceutical trials. that really looked at, trying to reduce vascular burden in individuals with cerebral small vessel disease. We also saw a significant reduction in diastolic blood pressure to the degree that it may confer protection against future stroke. Again, just as a reminder, individuals with cerebral small vessel disease are at greater risk for sustaining a stroke. Now, here is an interesting slide I want to highlight, and this relates to who benefits. So there's actually quite a bit of evidence to suggest that females benefit more so than males when it comes to aerobic exercise, such that even in our particular trial, we found that females benefited more than males in regards to improved executive functions. So we measure executive functions using, again, standard neuropsychological testing. And here what we found is that those who are trained aerobically, females benefit more than males. And this, again, aligns to prior literature and also to a prior meta-analyses that we conducted, whereby we included 39 randomized controlled trials in older healthy adults. And we found that essentially studies with higher proportion of females had basically demonstrated greater benefit of exercise, particularly aerobic exercise, as compared to studies with a lower percentage of females. And I'm sure there's some questions as to why, and those are great questions, but to be frank, we don't really have good answers right now. But it's certainly an observation that is being consistently seen across different studies. I will share that in our trial, we did collect blood and we did look at levels of BDNF before and after aerobic training. So BDNF stands for brain-derived neurotrophic factor, and it is presumed that aerobic exercises promotes brain health and thus cognitive function by increasing BDNF, which has positive effects on neurogenesis within the brain. And what we found is among the aerobically trained individuals, it was only the females who demonstrated an increase in BDNF, while males did not after 6 months of training. Again, why that would be, we're not sure, but just to share that there is some evidence to suggest that there is differences in mechanisms by which exercise promotes outcomes between the sexes. So as a summary, just to be clear, the evidence would suggest that different types of exercise training can promote cognitive and brain outcomes in older adults with and without impairment. Exercise, particularly resistance training, can slow down the progression of cerebral small vessel disease, a key driver of vascular cognitive impairment, and that there is evidence to suggest that females may benefit more so than males, particularly when it comes to aerobic training, although there is now some evidence being generated by us for resistance training. So then recommendations. So given sort of what we know, what would be some evidence-based recommendations? Well, from what we do know currently, the forms of exercise that seem to be beneficial for cognitive function include aerobic exercise, resistance training, and Tai Chi. I know I haven't shown any specific studies on Tai Chi per se today, but I'm gleaning now from the overall body of literature, and Tai Chi has come up as a mode of exercise that could be beneficial for cognitive health. When it comes to intensity, the evidence would support moderate to vigorous intensity. And sometimes when I say that, I do get a chuckle from people saying, well, that's not really doable. And I just want to highlight when we talk about intensity is tailored to the individual. So if you are somebody who is quite fit, that your moderate to vigorous intensity when measured by heart rate would be much higher. Like you would have to work much harder to hit a moderate to vigorous intensity as compared to someone who is less fit. So just to share that we're talking about tailoring it to the individual level. So moderate to vigorous intensity does vary as in terms of what that heart rate target would be across individuals. In terms of how long, the evidence would suggest a minimum 45 minutes per session. Certainly in our research program, all sessions are about 60 minutes with about 10 minutes dedicated to warm up and a cool down. And in terms of frequency per week is twice a week would be the minimum based on evidence. That said, the really key part is that you just need to start moving. So I just want to remind all of you about the one cohort study that really suggests 1 kilometer per day could be helpful. We know that, some movement is better than no movement, and there is a lot of evidence to show that if you're actually sedentary, any activity you do could be of high benefit as compared to, let's say, really fit individual who then increases their volume of exercise or physical activity. So those who are most sedentary actually benefit the most from any change in their physical activity as compared to more fit individuals. And the good news is that once you do start moving, you will become more motivated to engage in exercise. And I think many of you have experienced that. I don't think anyone ever regrets that they went out and completed a walk or went out and, joined their friends for a exercise class at the community center. We all feel pretty good after completing the exercise or some type of physical activity. And that's because when we are engaging in physical activity, our brain releases endorphins and dopamine. And, that sense of, reward and feel good sensation is a driver for your next session that you are thinking about to engage in. So it is a bit of a circle, a positive loop, but you do have to start. And ways to start, if you're having a hard time, we always recommend, developing SMART goals. And that stands for specific, measurable, attainable, relevant, and time-bound. So as an example, it could be as simple and as specific as I will do five sit-to stands every morning. And when I say sit-to stands, I mean sitting in a chair, getting up, and going back down again, and 5 times. And measurable would be that, I will track how many I do each day. Attainable, meaning that, that it's easy or that it's reachable for you or feasible for you to do. And a lot of times we also think about how to make that make it as easy as possible. So for example, I will set up a chair in my bedroom. So there's just is a reminder, is a physical reminder, and makes it super easy. And so that, there's less excuses or barriers along the way. Relevant, so that the goal is important to you, so I can get out of my chair better. Getting out of a chair is really important. It's critical for functional independence, and very often as we age, older adults do lose these functional abilities. That's why a lot of people stop taking a bath, because they can't get in and out of a bathtub. And time bound, that you will do this for the next 2 weeks. So SMART goals is a really great framework to developing a strategy. And then the other piece is that, sometimes I play psychological games with myself, and you can reframe your thinking. So again, most of us have a hard time engaging in regular physical activity because we're all busy for different reasons. We have different hobbies, different things in life that we want to tackle. And so, thinking about taking the time out to exercise in the moment can be a challenge. And so I really love this one commentary that my own PhD supervisor, Karam Khan, published back in 2009, which is that, we have 24 hours in a day. So maybe we can think about limiting our sitting and lying down to just 23 and a half hours. Right? So, if I can take 30 minutes out to engage in a walk, perhaps flip the notion that, I'm just going to limit my sedentary behavior to just 23 and a half hours. And I think most of us, when we reframe it that way, you recognize that we do have time. And my last 2 slides really just emphasize that what we do every day really does matter. It's about consistency and adhering to these small habits. So 2 large studies have really shown this. One is the finger trial, which was published by The Lancet back in 2015, which really showed a sort of like a multi-domain approach was beneficial in preventing cognitive decline. So that included diet, exercise, cognitive training, and vascular risk monitoring. And then more recently, the US pointer trial also, again, taking a similar approach, also showed that, by doing a little bit of good in all aspects of risk domains, we can promote cognitive health. That said, I will still say this. If you find it overwhelming to start, pick one. And I'm always a big advocate for exercise, and just think about starting small and having it manageable, but that you can adhere to consistently. So at this time, I just want to say that everything I've shared with you is really the results of excellent grad students and research staff that I've really had the pleasure to work with. And of course, participants who really have dedicated their time to us, even throughout COVID. As you probably saw on some of the slides, some of our studies were impacted by COVID-19, and we truly still had the best participants in terms of people still showing up for us and being very dedicated to the research, and then just acknowledging our funding sources, because obviously without funding, none of our research would be possible. So I'm going to stop sharing now.
Thank you, Teresa. That was very informative and a lot of information in there for us to process. For people in in attendance, be sure to somehow indicate that you would like to ask a question. There's a little bit showing up on chat, but not too much yet. So either write your question in there or put your hand up in the React button. And okay, so maybe Bev Lundgren had her hand up, and is this can work? Sandra and Sarah, you can tell me whether this is working. Because can Bev turn her audio on?
Yeah.
Well, while that's getting sorted, maybe I'll ask a question from the chat. And this is going back to your slide about the BDNF and the difference between men and women. On the slide, it appeared that men who exercise had a decrease in BDNF. Was this significant?
Yeah, there was this like a trend for a reduction. So the difference, it was not significant per se within before and after, but the significance was between the males, between the male and females, meaning that because it went in different direction, that they essentially were showing significance, with females tending to increase and the males tending to decrease.
Mm-hmm. Okay, thank you. All right. Oh, here's a question about continuity in your exercise session. So do you have to do your 1 kilometer all at once, or can you spread it out over different sessions and accumulate it during the day?
Yeah, no, that's a great question. I think the evidence would suggest that it could be broken up in the day and still be beneficial. So I think there's a researcher out at UBC Okanagan, Jonathan Little. So I think he phrased exercise snacks.
Okay.
And yeah, and I don't know if he's looked directly at cognition as an outcome, but he certainly has looked at its impact on, I think, insulin regulation and et cetera. And that, even brief bouts of exercise could be very beneficial for regulating your insulin, which I think it is really important for your overall brain health.
Yeah. Okay. Thank you. We have a question here about type of exercise, and that is whether you would consider Pilates as a resistance training or what?
Yeah, so Pilates, I would call it more of I think we would categorize it as a mind body exercise, which we also would categorize Tai Chi as, whereby there is some component of strengthening, but is what we would call functional strengthening more than a progressive resistance training. So if today I was going to do a meta-analysis, I would put Pilates under a mind-body exercise category.
Yeah. Thank you. But as a Pilates participant myself, I would say it is progressive, because every time you get to a certain level, they push up your weight or give you a more difficult exercise. So it's not a forced progression like in your studies, but it is a progression according to individual.
I agree. Yeah. So sorry, I should rephrase. Like, it's not progress specifically on the loading, the external loading. Like Tai Chi also can progress in forms as well. And I do want to emphasize that right now there is emerging evidence to show these type of mind-body exercises can be of great benefit for not only cognitive outcomes, but also on falls.
Uh-huh. Yeah, so people have talked about dancing as a good exercise because it does involve both mind and
Yeah,
body. Yeah.
for sure.
Carolyn, I just want to say that Paul has his hand up.
Okay, Paul. I'm trying to monitor the chat. Paul, what would you like to ask your question?
Oh, thank you. Teresa, I found this very fascinating, the ways that you and others have found to probe the brain and give us some answers. But as a male, I'm looking for a glimmer of hope here. What should I be doing?
Yeah, no, I know. This is where I always get a little bit hesitant about sharing the sex differences. I would say the evidence is not suggesting that males don't benefit per se, because again, on a group level, we see that on average, everybody would benefit or is benefiting. How I would interpret the existing results is such that I think it's because females may be starting at a bit of a deficit, because again, there is now a lot of recognition. And again, I mentioned this briefly, but then I didn't go into it. But as women go through the stage of perimenopause and menopause, there are some real significant changes that's happening. And certainly for males, they also go through, certain changes as well, but it's not as drastic or rapid. And so we do wonder if because of that, it's almost like there is a greater sort of room for improvement among females. Then from a gender perspective, I would also say that, again, not to stereotype, but women tend to adhere better to lifestyle interventions as a whole. And then also the socialization, which someone I think brought up in the group chat as well. We also do wonder potentially that could also feed into it as well. Like within our study, we do try to control for the socialization by having the active control group in a group based as well. But some people enjoy being in a social environment more than others, right? And therefore they may benefit from that socialization more so than another individual. And so it's hard to tease out some of those components other than the exercise piece, if that makes sense.
Thank you.
Okay. When you're talking about walking programs, does it make a difference if the walking is done alone or with someone else? Does the social factor contribute?
Yeah, I mean, we do think the socialization does matter. But that said, I will also share we've done studies on home-based exercise programming as well. So I didn't share that today because it was mostly within our falls sort of pillar of research. But in those studies, even we did see a significant benefit for cognition. So in those cases, there are individual exercises and people did still see a benefit.
Okay, great. Do you have any comments about the UBC Changing Aging program?
Yeah, no, I think it's a great program. It's out of I think they have multiple locations now, which is great. So my understanding is that it's one that is supported by the UBC School of Kinesiology, right? Maybe Anne can speak more to that. I think she's the one who posted about the but anyways, it is a program tailored for exercise in older adults. And it is in conjunction, my understanding, with the School of Kinesiology.
Yeah. Okay. So if you have an exercise like cross Nordic skiing, would you count that as both aerobic and resistance? Or, I mean, if you're pushing for more speed and greater distances, or is that just aerobic?
Yeah, I mean, there is definitely some strength involved as well. Usually when we categorize like strength training, there has to be some type of progression over time, so that you're always incrementally increasing it. So it certainly would be maintaining your strength, but I wouldn't expect the person to get stronger if they continue to do the same trails over time. But that's also probably true for their cardiovascular to a certain degree as well, right? So anytime we want to induce a change, we do need to make something a bit different about the exercise.
Great. Okay, one of our participants wants to know if weight was considered as a factor for participants in your trials. If a person is overweight, how does weight loss improve cognitive function? Perhaps indirectly rather than directly?
We have explored that. So it hasn't been like a primary pathway that we've been probing. Although, so the interesting part about fat, like adipose tissue and aging, is that yes, when we're younger and kind of before we're 65, the evidence would suggest that you should maintain a lower body mass index and, and be careful about gaining too much weight. In older adults, the evidence is actually a little bit muddled in some ways that, if an older adult is actually too lean, often that's associated with adverse outcomes as well and poor cognition. But that's also because weight loss is associated with physical frailty, which is a multi-system condition. So it's not, I guess just to say that when it comes to weight loss in older adults, I don't think of it as the same way as I think of it in an otherwise healthy individual. Like my son, I think he can lose a few pounds, and I would not be concerned if he lost weight. But for an older adult, unless it's intentional, you always wonder. And then there's some suggestion that some fat is protective.
That's interesting. Okay.
Yeah, I know it's counterintuitive, but it is actually quite an interesting set of evidence that's coming out.
Okay. Going back to your trials and your studies, is there an impact of volunteer bias in your trials? And in other words, how representatives were your participants to the general of the general?
Yeah, no, and that's always a great question. I mean, like I would say for sure, most of our participants are definitely more highly educated. We do try to increase reach through the way we advertise. So we actually advertise through bus ads quite a bit so that we are targeting people from different neighborhoods, not just kind of within Vancouver, VGH, UBC type of areas. We do recruit and do have quite a few people from different areas like Burnaby, Richmond, even Surrey, and also from different ethnic groups. But the one thing I will say is that they, on average, are more educated than not.
Yeah. So do you actually keep a record of those variables?
Yep, we do.
Yeah.
Yeah.
Okay. Yeah. All right. I have a question, but I don't see any more hands. If there are, please let us know right away. Okay. My question is going back to the beginning of your talk. You talked about the two measures of the hippocampus size in relation to memory and also executive function and the relationship between those. But just thinking of some people I know and know about who've had dementia, some people seem to be very, well, of course, I can't see their hippocampus size, but they seem to be very unrelated. Like some of them, it seems to be the executive function is really wacky, but everything else seems to be okay. And for some people, it seems to be the other way around. So is there a dissociation at all there?
No dissociation. I think it's more about the primary driver of the cause of their cognitive impairment. So again, in my own research, we tend to focus on the vascular aspect. So, and so when it comes to memory impairment, that is the dominant sort of manifestation for Alzheimer's disease. When you're looking at impaired executive functions, but pretty intact memory, you're probably looking at more vascular components like vascular cognitive impairment due to cerebral small vessel disease. Because what happens with the white matter lesions, because they are scattered around the brain. And so I think in some ways it interrupts lot of the communications between different brain regions, and our executive function does rely on this coordination of all areas of the brain. And so, yeah, what you describe, I would attribute to what is the primary driver of their impairment.
Right. And if you does cognitive reserve come into play when you're talking about executive function at all? I mean, so are you protected in some way if there are things that like all of us in our group are highly educated, for example?
Yeah, so cognitive reserve is a concept that we're all, not just us, but all trying to understand better. We see it. So, the observation would be exactly that, whereby, let's say you have somebody who has all these chronic conditions, and maybe even on neuroimaging, they have a very small hippocampus or even just general atrophy, but somehow they're still maintaining cognitive capacities. And we do hypothesize it's probably related how they're using their brain. So it's not just the structure, because how we perform is not just dependent on the structure, which I would akin to be kind of like the computer hardware, so how much memory you have, but then also kind of the software, which is like, how does your different brain kind of work together functionally. And so the reserve piece is probably related to how the brain functions versus the structural changes that we have observed as a result of pathology or disease.
Yeah. Okay.
I don't know if I'm making I'm
That
answering
was helpful. Yeah.
Yeah.
Okay. Sandra Bressler, I see you up there. Do you have a question?
I do. Firstly, Teresa, thank you for this presentation. It is so helpful, and you have recommended so many items, exercises to think about. I just wanted to ask you about falls and falls prevention, because in my age group, that seems to be a number one issue with friends, etc. And of what you have described, what would you feel would be the best recommendation to make to work at preventing falls, exercises, where to go? I mean, you've talked about Pilates, yoga. What is your feeling about that?
Yeah, no, thanks for asking that. And I guess I should also share that with falls, we actually know that it is actually related to your brain health as well. So just pure stats perspective, in otherwise cognitively healthy community, older adults, we expect 1 in 3 will fall per year. And individuals with some degree of cognitive impairment and not dementia, it could be upwards to 1 in 2. And then those with dementia is actually much higher than that. Now, when it comes to exercise for falls prevention, that we actually know very, very well. So it's a combination of balance training that is progressive over time, and also combined with strength training. And with the balance training, that in itself also does have an impact on the brain, because for you to balance, your brain has to basically make sense of all the sensory information that is being fed to it, proprioception, your visual, even your vestibular, make sense of it, and then allow you to maintain upright balance. So balance training is critical in falls prevention programming, as well as strength training as well. And then we also do recommend some walking just to maintain mobility.
And of yoga, Pilates, that's more.
Yeah, I will say, so there was a specific trial out of Australia. Our colleagues conducted it. It was Stephen Lord's group. They're actually one of these world leaders in falls prevention. They did do one on yoga, and they didn't find a significant effect. So when it comes to the evidence for reducing falls, the type of exercise, hands down, most evidence-based, is balance with strength training.
Okay, good. Thank you.
You're welcome.
Okay, as we end, one of our members, Suzanne Campbell, would like to remind us that there is a walking program and that there have been 2 teams for the Emeritus College. So I assume that folks in the office will help you join one of those if it's something you'd like to do.
Just let us know. Yes, it's the Walk for Joy that we do every
So good.
every
And
winter.
then we have a new special interest group in walking in Pacific Spirit, so that's also a possibility for
Yeah, actually, if I
led by somebody who's well over 90. So yeah.
and sorry if I just can have a second, Carol, just because you mentioned the four. So fun fact, we actually right now we've submitted this and is being reviewed and hopefully will get accepted soon. But we actually did a comparison of walking in the forest versus walking on the treadmill. Because, you know, there's a lot of literature to suggest being in the green space is also really beneficial. So we actually did see that walking in the forest was more beneficial than just walking on the treadmill.
Oh,
Okay.
okay.
So yeah, so just thought I'd share that because we were quite surprised ourselves, to be honest, but yeah. Yeah.
Well, this has been a really great meeting. Thank you very, very, very much. I think we should probably excuse you before we do our little talk about polls and the continuation of the series. But thank you. And as a token of our high esteem, we will be getting to you one of our coveted Emeritus College umbrellas. So we will arrange that with you separately.
Okay.
Okay.
Thank you so
Thanks
much.
so much. It's been a great meeting. Yeah.
Bye.
Bye.